Imagine living for years with constant pain, fatigue, headaches, brain fog, GI problems, joint instability, and constant exhaustion, only to be told that all your labs are normal. Perhaps you've been labeled to have fibromyalgia, depression, anxiety, or just stress. Well, what if all your symptoms could be explained by a connective tissue disorder? That's what we're going to talk about today on the Dr. Dustin Show. Hello everyone, and welcome again to another episode of the Dr. Dustin Show. I am Dr. Dustin, a double board certified pain management specialist, and this month is Fibromyalgia Awareness Month. We've been talking about how to diagnose fibromyalgia, some of the complications that can occur, and other things that fibromyalgia is associated with. And today is along those lines, actually a topic sent in by a viewer who shall remain anonymous at this time. And let me just tell you real quick, for other healthcare providers out there that may be watching this, never underestimate your patients. Your patients know probably a whole lot more than you do about their particular condition. You know, we might say, oh, but I've been studying at, 4 years of medical school and we went to residency and fellowship. Okay, that's all fine. But have you been living with it? Because these patients have been living with it, and they know really all the ins and outs, at least from their perspective. I got a file, probably over 60 different published studies that are talking about today's topic because of this viewer really wanted to make sure that we were educated on what this person was experiencing. And so, first of all, hats off. I love a patient that does their own research. I think it's kind of funny that doctors get a little insecure or even perturbed when patients go onto Google and research things for themselves. No, the days of old are gone, okay? This is the modern age of the internet, and if you are threatened by your patient doing primary research, then perhaps you need to also be doing your own primary research as well. So, again, hats off to patients who take that responsibility and bring that to your physician. Have that conversation. Hey, what does this study mean? Hey, I noticed this, big word. What does that mean? We can have that conversation, and that really is where I think the best medical care can happen. If it can't happen in the exam room, by golly, it can happen here on the Eclipse Pain Network. So if you are a new viewer or a new subscriber, welcome to the channel. We are glad to have you. So let's get into today's topic, fibromyalgia and connective tissue disease. Well, there's a lot of overlap between the two. Perhaps the most common is Hypermobile Ehlers-Danlos Syndrome, abbreviated hEDS, and henceforth I will refer to it as hEDS because it's just a whole lot easier to say. Perhaps you've noticed that yourself or maybe members of your family, whenever you get an injury, it kind of takes you a while to heal. Perhaps you bruise easily, or everyone is just kind of generally flexible. You've never really had to do much other than just do the splits. That was something that you could always do. Perhaps you go to the doctor or the dentist and they try to numb you up with lidocaine, but it never quite works well. You feel like you're resistant to lidocaine or other anesthetic agents. Well, all of those could be clues that you have more going on than what meets the eye. To demonstrate, let's pull up a chart. I want to show you if you've ever been diagnosed with fibromyalgia, but you feel like there's just maybe some pieces missing, or maybe you just didn't get a full diagnosis, or perhaps you've even felt dismissed in the doctor-patient encounter. Here's why. If you look at a chart of fibromyalgia and hEDS, each one of these can result in widespread pain, fatigue, brain fog, poor sleep, anxiety, GI symptoms, headaches, and exercise intolerance, perhaps for different reasons, but nonetheless. So you have this whole body pain, and it's kind of wearing you down. You feel like, just living life each day is getting harder and harder. And you try to explain this to your doctor, maybe your pain doctor, and you get a diagnosis of fibromyalgia. Then, of course, you get put on treatments and sent off to the physical therapist to start some exercise. After all, we know exercise can be very helpful for patients with fibromyalgia, but it seems in this case, perhaps the medications, they just aren't working, and sleep is still a big problem. And every time you go to the therapist, your pain gets worse, and you come back to the doctors 4 to 6 weeks later, and you're like, hey, I've been very compliant with this plan of care, but by golly, nothing seems to work. In fact, it might even be getting worse. Well, worst case scenario, and I know perhaps a lot of you in the comments section may have experienced either dismissal, outright dismissal, or just advice to just push through it, keep trying, or maybe even accused of drug-seeking behavior. If you're dealing with these symptoms and you're giving it your full earnest best, and you get this type of response from your physician, certainly that can be very demoralizing and frustrating, to say the least, especially if this cycle continues month after month, year after year. Well, some of the things that could be going on here is that you don't just have fibromyalgia, or maybe you don't even have fibromyalgia at all. Maybe you have a connective tissue disease. Again, the most common one is hEDS. So how do we diagnose hEDS? And the question is, have you ever been put through this diagnostic regimen? Let's take a look. There's a chart called the Beighton score, and the Beighton score basically assesses how flexible you are. You can see on the top left of your screen, if you pull your pinky finger back and it extends beyond 90 degrees, you get 1 point for the right side and an additional point for the left side if that's the case. Additionally, if you can pull your thumb back and touch your forearm, you get an additional point, 1 for each side. If you can bend your elbow backwards, I know a lot of you might be double jointed in the elbow. I happen to be double jointed as well, but just on one side. In this case, you get 1 point for each side. If you can bend your knee backwards beyond 10 degrees, again, 1 point for each side. And without really trying, if you can just stand there and put the palms of your hands on the floor without bending your knees, you get an additional point for that. So you add all those points up. And if you are an adult and you have 5 or more points out of the possible 9, then that might suggest you have joint hypermobility. If we're on a borderline here, maybe you have a score of 4, maybe even 3, but it's a very strong 3, then we put a heavy emphasis on your past medical history, or maybe even your family history. When you were a kid, were you in gymnastics? Could you do the splits? Could you put your hands behind your waist and then pull them up over your head without letting go? These types of fancy maneuvers might suggest, at least at some point, you had some joint hypermobility. And especially as we age, even in conditions like hEDS, you can lose joint mobility just because over time those joints start to wear out. You begin to develop degenerative joint disease or arthritis. Pain comes along with that, and guarding. And the muscles tighten up, actually, not just because they're tight to begin with, but more of like a compensatory mechanism to protect yourself against the pain. So you might have had this your whole life, and you would still have it in your older age, but perhaps you can't stretch as much as you could. So a history is going to be real important here as well. Now, beyond, let's say, testing positive, the history might include recurrent dislocations. Do you or members of your family frequently sprain your ankle, right? Can you see on your shoulder, perhaps you have your scapula on the back. It moves way out whenever you move your arm up and down, right? Some scapular instability. Perhaps when you're sitting there on the couch, you can play with your kneecap and slide it all the way over to the side, right? That would be something worth noting. A lot of patients with hEDS will complain of reduced body awareness or reduced proprioception, right? They have trouble knowing where their body is at in space. And this can result in some clumsiness, bumping into things, tripping, falling, things of that nature. And that can be a sign as well. Patients with hEDS tend to walk a little differently, and that might result in some knee hyperextension, or what we call genu recurvatum. A picture of that is quite dramatic. You can see on the left-hand side there, when they walk, their knee sort of bends back. Now, again, just having a primary knee problem can result in a gait that looks like this, but taking this gait pattern into the context of everything else is what is important here. So beyond joint instability and gait abnormalities and clumsiness and things of that nature, to really pin down the diagnosis of hEDS, we want to see some systemic soft tissue features. This might include soft or velvety skin, hernias or even pelvic organ prolapse, dental crowding with a high palate, and perhaps even more concerning, you can have cardiac dysfunction as well. You might have a murmur. You might be diagnosed with mitral valve prolapse. You may even have some aortic dilation that can result in some, not only symptoms, chest pain or feeling like your heart's beating out of your chest, but it can also result in blood pressure issues, heart rate issues, feeling like you have trouble standing up or exercising. And so, especially if you find those things on exam, or if you have a strong family history of cardiac problems, a cardiology evaluation, perhaps even an echocardiogram, strongly recommended. One particular thing that affects patients with hEDS, perhaps even more commonly than it does patients with fibromyalgia, is autonomic dysfunction or dysautonomia. And some common symptoms of that will include dizziness, palpitations, tachycardia like we talked about. Now again, that can be just from the dysautonomia, but if you have primary heart problems, it can be associated with that as well. Exercise intolerance, brain fog, nausea, temperature dysregulation, and feeling like you are about to pass out or having a history of passing out. Now, there was a 2025 study that came out that showed perhaps greater than 90% of patients with hEDS are diagnosed with autonomic dysfunction. If we can pull that study up, I'll show you there. POTS prevalence is actually around 33%. Small fiber neuropathy affects about 82%. So here's the study here, Hypermobile Ehlers-Danlos Syndrome, or hEDS, and the implications with cerebrovascular, autonomic, and neuropathic features. This is the big reason that I can see why it's so important to make sure that you actually have fibromyalgia, or there could be other things going on, because there can be significant health implications here as well, perhaps more than just living with chronic daily pain. The autonomic nervous system affects your heart rate, your blood pressure, sweating, digestion, temperature regulation, all of those things. And so proper treatment of those things is important, is vital. It affects how you live your daily life. If every time you get up and the blood pools in your feet and in your legs and you feel like passing out, again, you might just be written off as having poor endurance, or like you haven't exercised in a long time, you're debilitated. And so they push you into physical therapy. And if the physical therapy is not the right type of physical therapy, it can actually make things a whole lot worse, and you will feel very defeated in this process. So what does good physical therapy look like? Well, if you have hEDS, we're going to start with simple range of motion, and we're not going to do exercises at the end of your range of motion. We're going to keep everything sort of close to the body. We're going to focus on restricted range of movement, so using machines versus using free weights. We're not going to do heavy weights until we know that you're stable in at least the lower end of your range of motion. And we're not going to use a philosophy where if you start to hurt, we're just going to push you through it, because again, that can be a sign that the joint itself is not stable and contributing to that flare, to that pain. When we're talking about hEDS versus fibromyalgia, there's really two different types of pain, right? And again, that's why it's so important to know what it is we're dealing with. Fibromyalgia, as we've talked about this month, is a centralized pain condition. So it affects the brain, primarily the spinal cord, and how the brain interprets painful signals. It's almost like the dial is turned up way too loud. And so the treatment focuses on that type of pain. We call it nociplastic type pain. And that's why we have treatments that affect those neurotransmitters in the brain, like duloxetine or even pregabalin, that type of thing. But are those treatments really effective for a patient with hEDS? See, hEDS is a different type of pain. It's a nociceptive type pain. It's primarily coming from the joints, the muscles, the ligaments that are being stretched, strained, and injured, essentially. And so primary neuropathic type medications may not be as effective for that as well. And so again, it's so important to be able to identify the differences between these two conditions and provide the appropriate treatment, not only from a physical therapy perspective, right? Because stretching can really help fibromyalgia, but stretching may cause hEDS to get worse. It may contribute to that joint instability. So not only is this important from, I think, a patient validation perspective and an education perspective, but also from a treatment approach and also from an approach to identify comorbidities. Like I mentioned earlier, cardiac problems, GI problems, right? Joint problems that we may need to prepare for, whether it's surgery or bracing, or even just knowing that you may not respond as well to lidocaine, and it's not just in your head, so to speak. A hypermobile body doesn't need more flexibility, it needs more control. And again, that's sort of the big differentiating factor. It does take a little bit more work to diagnose Ehlers-Danlos. It does take a little bit more listening, a little bit more examination, and it can take a little bit more time to get to the bottom of it. But I think it's important to highlight this, especially in this month as we talk about fibromyalgia and we raise awareness for fibromyalgia. There are coexisting conditions. And by the way, it's not either or. It's not fibromyalgia or Ehlers-Danlos. Oftentimes they are in combination. Oftentimes, if you start off with Ehlers-Danlos and it goes undiagnosed for so long, that nociceptive pain type can progress into a centralized pain condition and develop into fibromyalgia. So it is a very complex physiology and it can be difficult to diagnose. But if any of these symptoms seem to speak to you, or you identify with any of these conditions, just know that it may be more than just fibromyalgia. And again, hats off to the viewer who sent in this topic and all of the research articles to go along with it. I'm impressed, and hopefully we can continue this conversation to help as many people live more with less pain. I am Dr. Leek. This is the Dr. Dustin Show. Until next time, take care.